and this is our fourth and final lecture on mitral regurgitation. With this lecture here, we'll review the regurgitant fraction calculation and look at ways of determining the effective orifice area. We'll apply the Pisa equation for mitral regurgitation, its most common and accurate application. There are a number of considerations that must be made that differ from its application when it comes to stenosis. Then we'll explore the use of MR for the assessment of LV systolic function by the DP-DT method. So working out the regurgitant fraction, it's simply an expression of the percentage of regurgitant volume compared to the normal forward stroke volume. It's represented by the formula here. The regurgitant fraction is equal to the regurgitant volume times 100 divided by the stroke volume. So times 100 there to get our percentage. So from this, we can work out regurgitant orifice areas. Much in the same way that we determine the area of a stenotic valve, we can assess for the size of a leaking area. We have already described that flow is equal to the cross-sectional area multiplied by the velocity time integral. So substituting for what we want to evaluate, regurgitant volume can be expressed as Q, and the effective orifice area is equivalent to the cross-sectional area. So our standard flow equation can then be substituted with the factors there, and we want to know the effective regurgitant orifice area, so we just rearrange our calculation slightly. So here's an example of it all. So my previous one, we had a mitral valve with a regurgitant volume of 66 mils, and we knew the stroke volume through that regurgitant valve was 108. So the regurgitant fraction is 61%. Then working further to have the regurgitant orifice area, knowing the features that we have there, it's simply 66 divided by 37, and our effective orifice is 1.8 centimeters squared. So we can use these numbers to help identify what we want to see with mild, moderate, severe, or severe mitral regurgitation. So here's our table for the regurgitant volume and regurgitant fractions. Note with the assumptions listed earlier for how we derive stroke volumes, a regurgitant fraction compounds the potential problem further by introducing the leaking valve stroke volume. Inappropriately measuring the mitral annulus in MR would lead to the error being presented twice. The proximal isovelocity surface area is another method we may deploy to evaluate the regurgitant valve. It's also based on the same principle of conservation of mass. So this calculation here makes the assumption that flow through a regurgitant orifice is equal to flow within a hemisphere just above it. What we do is we measure a radius from the leaflets of the valves to this hemisphere, and we know the hemisphere area is 2 pi r squared. So knowing our stroke volume calculation again, our cross-section area is now substituted for 2 pi r squared. But why do we use a velocity instead of a velocity time integral now? This is because we are using a specific velocity defined on the machine to determine the radius, or the hemisphere that we use. The velocity at this point is neither accelerating nor decelerating. It's uniform or unchanged, thus the term isovelocity. However, blood is accelerating as it moves closer to the orifice. Therefore, higher velocities equate to smaller radiuses. As blood progresses towards a regurgitant orifice, it increases in velocity, and the hemispheres associated with each velocity progressively decrease in size. The specific velocity of any specified hemisphere is uniform. So our specified velocity is always Vn, the aliasing velocity we have. So we can show here flow the regurgitant valve is equal to flow within the hemisphere. So cross-sectional area, cross-sectional times VTI, and again substituting things around, we get an effective orifice area is 2 pi r squared at the aliasing velocity divided by the regurgitant velocity. So putting Pisa into practice, if we had our MR velocity at 5.5 meters per second, our radius was measured at 0.8 centimeters, and the aliasing velocity where we got our radius at 0.45. We could throw it all in, convert to centimeters, and we get our effective orifice area, 32 millimeters. So working out regurgitant volumes. Regurgitant volume is equal to the effective orifice area times the velocity time integral. Note here again, we've moved up to VTIs. We're assessing all the velocities moving through the valve over a period of time rather than an instantaneous point. The PISA method is readily utilized for the estimation of regurgitant volume severity. In the case of stroke volume calculation for mitral regurgitation, it is typically the LVOT place that is used for normal stroke volume, but this can't be used when there's aortic regurgitation, so PISA has its advantage here. Fortunately, the standard PISA can also be simplified. Not only is this a time-saving process, but is useful in instances where regurgitant jet is eccentric, imaging is suboptimal, or the sonographer is unable to obtain a jet alignment. We obtain simplified PISA by setting specific machine settings and making the assumption of MR velocity. In a patient that is normotensive, we expect to see a pressure gradient between the LA and the LV of 100 millimeters of mercury. That is basically a velocity of 5 meters per second for the MR jet. We know that pi approximates to 3.14. And so what we're doing is working at the flow in the regurgitant valve is equal to flow within the hemisphere and substituting what we know in there, not forgetting to convert meters per second to centimeters per second. We basically get 251.2 times the radius squared divided by 500, or effectively the radius squared divided by 2. So the ranges that we use for determining the severity of regurgitation, we can look at the effective orifice area, or actually the radius itself, when specifically we use an aliasing velocity of 38 centimeters per second. So if we had an EROA of greater than 40 millimeters, 0.4 centimeters squared, then we'd actually classify it as severe. And we will always come to our limitations, considerations, and assumptions. As with the limitations seen in other stroke volume calculations, the radius is an important component. An error in the derivation of the value can lead to an inaccurate valve regurgitant area, such as if we actually measured a radius of 0.6 centimeters instead of 0.8, we'd actually get vastly different values. The radius is measured in a specific point in time, which is mid-systole for mitral regurgitation. The radius is measured at a specific point in time, which is typically mid to late systole for mitral regurgitation. An effective orifice estimate is made of its flow at that particular point in time. This can over or underestimate the true anatomical orifice area. It is problematic to measure PISA in prolapse, as often the early to mid part of the signal is not even present. There is beat-to-beat variation, as seen with previous calculations, which can lead to error. That is important that numerous measurements are taken. Even in sinus rhythm, a sonographer who averages 3 to 5 measurements will deliver a more desirable result. And then, of course, when we have AF by Germany, frequent ectopic beats, then up to 8 measurements will improve the accuracy. There is also considerations for the determination of the hemispheres. The isovelocity contours or effective shells flatten immediately proximal to the orifice, effectively changing the shape of the assumed volume, which is no longer a hemisphere, and thus what we assume is incorrect. Using a baseline shift that is not too extreme, i.e. a higher aliasing velocity, minimizes this effect. Additionally, the orifice shape may be irregular, so the hemisphere doesn't accurately represent the shape of flow convergence. Another example is with microgurgitation, where multiple sites of flow can occur. The sonographer must also consider that structures do not remain stable in the imaging plane throughout the cardiac cycle. In mitral valve prolapse, the leaflet moves towards the atrial systole, and this motion can lead to a subtraction in the isovelocity contours and effectively underestimation of the regurgitation severity. In some instances, the regurgitation is eccentric, and the velocity cannot be accurately measured. In this instance, a simplified PISA may have to be considered. The user must also be wary of other flows that may influence a hemisphere shape, such as high velocities through the LVOT, which may be seen in systole, particularly with obstruction or rigorous LV systolic function. The LVOT flow may contaminate the LMR flow convergence and lead to the formation of a distorted hemisphere. In this example here, we've got flail involving the anterior leaflet of the mitral valve, and we can see that the wall hugging jet hits and rolls around. We can still measure a hemisphere, but the difficulty may be in actually getting the correct alignment for the Doppler signal there. We can also use stress echo for mitral regurgitation. Stress echo is useful to evaluate the patient's tolerance to exertion. This may be considered by a surgeon to determine the appropriate time to intervene to repair or replace the valve. The BP response to stress exercise and increased contractility may lead to increased mitral regurgitation, which may in turn put increased pressure on the lungs and raise the pulmonary artery systolic pressure. Dynamic flow obstruction may be further increased as part of increased contractility, and in some instances, decreased LV cavity size associated with peripheral dilatation will also increase this obstruction. As chordae are drawn upwards, an increase in eccentric mitral regurgitation may be seen post-exercise as part of this process. Assessment of the patient during and post-exercise is important, along with blood pressure recordings. Has the patient developed marked shortness of breath post-exercise? Has the patient's blood pressure dropped associated with obstruction? The most important factor is to determine the pulmonary artery systolic pressure post-exercise. It is normal to increase, but not markedly. When we start seeing velocities above 3.5 meters per second, we get concerned. Associated with this may be right ventricular function failure. Due to the challenges of time constraint and image quality, usually a visual assessment is made of the mitral regurgitation post-exercise. We may also use mitral regurgitation to assess LV systolic function. These flow profiles are applied with a method called DPDT. The D represents delta, which is change. Thus, it's the change in pressure generated over a change or period of time. Systole may be divided into two components, the isovolemic contraction time and systolic ejection period. In IVCT, the LV generates pressure with depolarization of the myocardium. The force isn't sufficient to overcome the aortic pressure and force the aortic valve open. However, an incompetent mitral valve will begin to leak as soon as the LV raises over what is a relatively low left atrial pressure. Hence, mitral regurgitation occurs in both periods and is often termed pansystolic murmur. We are interested in measuring the pressure change in the IVC2, the early component. The assumption is made that left atrial pressure doesn't increase during this period. Thus, we measure the instantaneous pressure gradient between the LV and the LA. Given the established relationship between velocity and pressure, we can imply that a rate of velocity increase represents a rate of pressure increase. What we'd expect to see is that the normal LV systolic function will generate the pressure rapidly compared to an impaired LV, which will take longer to generate the same pressure. So how do we go about doing it? We apply continuous wave Doppler with its best alignment to the mitral regurgitation. The sweep speed of the Doppler trace is set to high for ease of measuring two arbitrary points over this short period of time. These 2 points are chosen to represent the change in pressure. For simplicity of use and ease of obtaining the early part of the MR signal, the velocities of 1 meter per second and 3 centimeters per second are taken. Working with the modified Bernoulli equation, we know that 3 squared times 4 is 36, and 1 squared times 4 is 4. Thus, it's the pressure change between 36 minus 4, or 32 millimeters of mercury. So the dPdt is simply 32 divided by the time taken. So what we normally see is a short dPdt for a good ventricle, somewhere in the moderate range here, and severe, we're taking much longer to generate that process. We've described this principle as pressure over time, and thus the units of measure are millimeters of mercury per second. So in summary, again, we explore the possibility of using regurgitant fractions to estimate severity and the size of effective orifice areas. The PISA may be applied to both regurgitant or stenosis lesions. However, there are slightly different considerations that need to be applied when we look at mitral regurgitation. Stress echo is not always a contraindication to when we have mitral regurgitation and may be utilized to determine functional capacity in the patient, which is typically useful for patient management. Finally, we may use the MR to assess more than just its severity alone, but the flow profile can be used for the estimation of LV systolic function.